Well, welcome everyone. Good afternoon, and thank you for joining us for this FBI Cyber Series. My name is Nathalie Jette, and I'm a neurologist and epileptologist in the Department of Neurology. I'm Vice Chair in Neurology Clinical Research and Chief of the Division of Health Outcomes and Knowledge Translation Research. So I suspect that this talk is a little bit different than what you're normally used to. There's going to be more focus on Neuro-Epidemiology. And so I'm going to stop the video and I'm going to start sharing with you. And I hope that you're all safe and healthy, and thank you for joining us. So what I want to focus on today is, again, I'm going to discuss some neuroepidemiological findings. A lot of it is some of the work that our group has done over the years. I'm going to focus on depression and mortality in epilepsy and some of the findings that have been described that are really changing clinical practice. I hope that everyone can hear me well. So I don't have any relevant disclosure, but you can see here some of the funding. And what I will focus on, what I just mentioned, I'm going to focus a little bit more on depression, but also a bit on anxiety, and then finish by discussing some of the mortality studies and some of the gaps in the research and future directions. And so why is it so important to study depression and anxiety? And I'll talk about it more in a moment. And I know many of you who are on are psychiatrists or neuropsychiatrists, and I have a lot more expertise in this area than I do. But there are very important comorbidities of epilepsy. And you know, clinical practice, sometimes family members would come with patients and say, well, of course, he's depressed. He's having seizures. He's not able to drive. His wife left him. Why wouldn't he be depressed? You know, if we can treat the seizures and the depression will get better. But unfortunately, that's not always the case. You know, and this is a quote from a patient who said that having epilepsy doesn't mean that you have to expect and cope with depression. You have as much right as, you know, to help and support as anyone else. So just because someone has epilepsy or another neurological condition, we still need to address both condition, and definitely if we can improve seizure outcome, if we can improve other epilepsy outcomes, it will help the depression, but sometimes it's not enough. So how common is depression in epilepsy? Well, we had done a systematic review a while back. I had a student who was whose PhD focused on depression and epilepsy. And so as a first step, we looked at studies, that population-based study looking at the prevalence of depression and epilepsy. We identified over 7,000 abstracts. And in the end, looking at, you know, studies that some of them were better because some of them used a validated screening tool or semi-structured interviews or full psychiatric interviews, the overall prevalence of active depression ranged from about 13 to 37%, depending on the ascertainment method that we use to identify depression. And obviously, you know, the estimates vary depending on the source of ascertainment, the population, and so on. Others have done similar work looking at anxiety. This is a study by Amelia Scott in Australia, and they replicated the study we did looking at depressive disorder, and they got an overall pool prevalence of 22.9% for depression and 20% for epilepsy, for anxiety. And that's, again, population-based studies that have looked at the prevalence of these psychiatric comorbidities in epilepsy. This is a study that we had done a while back now, but it was a study looking at psychiatric comorbidity in epilepsy. It was a population-based study using the CD to diagnose psychiatric disorders. And it's been really, really highly cited because you can see that the CD was administered in over 36,000 people with epilepsy and over 250 people with epilepsy. So a very large sample size. And what we found is that those who had epilepsy had a higher prevalence of lifetime mental health disorder, almost 36% compared to the general population, almost double. And whether we looked at depression, anxiety, suicidal ideation, the estimates were always much higher in epilepsy. And you can see, for example, for major depressive disorder, lifetime was around 17.4%, 12 months. So kind of more like active depression was around 14%, about 5% in the general population, so much higher. And anxiety, also very high estimates. There have also been a lot of study looking at the bidirectional association between epilepsy and psychiatric disorders, depression, anxiety, psychosis. There have been different studies. This is a nice study done by the group at Columbia, where they used the UK General Practice Research Database, which is an EMR type database, and looked at the bidirectional association. And what they found is that epilepsy is associated with an increased risk of psychiatric disorder and suicide before and after the diagnosis. So more recently, one of our my mentee was interested to look at, again, at this bidirectional association, but to see if the association was stronger if someone had depression, if it was treated, and whether the different types of treatments could also be associated with epilepsy. So this was actually, this was a study it was an observational study of a population-based primary care cohort. The ages were age 18 to 90 years old. And this study included more than 10 million people, of which more than 229,000 developed depression, and close to 100,000, or almost 1%, developed epilepsy. So we used some of the UK EMR data, very large population, and also some of the local provincial data at the time when I was in Canada and Alberta, to do some more granular analysis as well. And so 2 different data sources were used. And what we found is that we did find that incident epilepsy, so new onset epilepsy, was associated with a higher hazard of developing depression at around 2. And same thing in the other direction, incident depression was also associated with an increased hazard of developing epilepsy. What we found also that was interesting, and I'm going to show you in the next slide, but one of the other findings is that the odds of failing to achieve 1-year seizure freedom was actually higher for those who had depression, whether it was treated or not. So people who had depression had a lower odds of being seizure free on medication. So definitely had a big impact. This is one of the figures from the paper where you can look at the cumulative hazard of developing epilepsy over time. The lower bar shows you if you have no depression, the hazard is lower. If you have depression, it's higher. And if you're on treatment for depression, even higher. And treatment could be if you had medication alone or counseling and so on. So if you had counseling, it was a little lower than if you were on medication and had counseling. So the more you were getting, the greater the risk of developing epilepsy. And we really do not believe that this is because antidepressants increase the risk of seizures. We just think that it just represents, the epilepsy, we often think of it as a network type of disorder, and we just, assume that, if there is depression, often the epilepsy is more severe, and there's just more, impact, overall. And so that's why there are obviously some shared pathogenesis, that where both can be associated, but we really do not believe that it's due to the treatment. We just think that it's a more severe type of epilepsy and so on. But again, these type of studies using EMR data, you cannot attribute causality. So this was just an association, but a very important one. So why is it important to screen for depression and anxiety and epilepsy? Well, I've told you that most of them are common in epilepsy, so and they have a big impact. We know that, for example, there have been many studies showing that if people have depression, that they don't respond as well to anti-seizure medication. They tend to have more medication side effects. They also have, I'm going to show you some data later, a higher risk of premature mortality. They have a quality of life will be lower, not surprisingly, and higher health resource utilization. There are some data I'm not showing you here where surgical outcomes in some studies were poor if someone had depression prior to surgery. Here's another study why it's so important to evaluate depression and psychosis and other psychological and psychiatric symptoms and condition. This was a study where, and it's a common occurrence, where back in 2016, from May to October, there was a shortage of an anti-seizure medication in Alberta, Canada, where I was practicing at the time. And so it was clobazam or Onfi. In Canada, it was called Frisium. We were interested. It happened almost overnight, where within about a day or two, all of a sudden, there was no more clobazam. And it was very, very difficult to get it. It happened close to a weekend, and we were bombarded by calls and panicking patients who couldn't get their medication and so on. It lasted for several weeks, and we did a lot of work with Health Canada and other groups to try to mitigate this serious issue. And because it was happening, we were really interested to know what was the impact on patients, because we knew that it really had a big impact on our nursing resources. And we were all trying to identify some of the medication, switching medication and so on. And it was a big impact on our epilepsy program. And we knew that it was likely a big impact on patients. So we had a database, and we were collecting prospective patient-reported outcomes in all of our patients. So we were able to very rapidly identify everyone who was on clobazam, and we got a rapid IRB approval. We did a mixed method where we did a questionnaire, and we also had some open-ended question that we analyzed qualitatively. And so we had 71 people who participated, so 84% of eligible patients agreed to participate. And one thing we found out, this was about 4 weeks into the drug shortage, that already more than 70% had a medication change. And they may still have been on the same medication, but they may have gone from generic to brand name, or they may have gone to a different company, or a different some of them had an actual change from clobazam to clonazepam and so on. So many had some type of medication change. And though we wouldn't think it would have an impact, we had some people go from, say, generic to brand name or vice versa. And both types of changes in some people resulted in pretty significant side effects. And I remember one young man who just went from generic to brand name and presented with significant toxicity and so on. So both ways, there was an impact. Anyways, when we looked at the quantitative patient-reported outcomes, where we just have a score, things like that, quality of life, or nothing had really, there weren't some big changes that were clinically meaningful. There wasn't really any change pre and post shortage. It wasn't until we did the qualitative analysis and listened to people's story that we saw that the psychological impact was really significant. And you can see most of the themes were not referenced very frequently, but if you look at the psychological impact, it was referenced 93 times, fear and anxiety about the future. And there's probably 100 quotes that I could include, but I've included one of them here just so you understand that if we only use the questionnaire, we wouldn't have found any impact. But when we looked at the qualitative aspect, it was really concerning. So this is a patient who said, when I first found out about the shortage, I panicked and I immediately worried that I was going to run out of my pills and thought far ahead. I have a problem with catastrophic thinking. I thought far ahead about if I run out of Frisium, which is Onfi, and if I have a seizure, and worried about losing my license and house, and then losing AISH, which is the social support assistance. When it got to that point, I thought about killing myself. The anxiety got that bad. And we had many, many examples like this. And so this is just another example of how, depression, anxiety, the psychological impact of, epilepsy and its associated, different outcomes are very important to consider. We also did some work again in Calgary, where we looked at patterns and frequency of treatment of depression in persons with epilepsy. And this is a program where I thought we were quite good, I thought, at identifying depressions in our patients. We really, many of us had an interest in this. But in this study, we had 185 adults who had SCID interviews to identify depression. And we actually found that 70% of those in our program who had depression were not being treated for it. Many of them, it was undiagnosed. And this has been consistently reported in other studies. And it wasn't that, people were ignoring it, but we weren't systematically evaluating it. We weren't systematically screening for it and confirming whether people had it or not, and then treat it if necessary. What we also found is that of those who had depression, 50% also endorsed suicidal ideation, which is obviously a big concern. Here's a study from Denmark where they did look at epilepsy and the risk of suicide. It was a population-based control. This is, they had, it was between 1981 and 1997, and they identified up to 20 controls to each cases of suicide by sex, birth year, and calendar date. So there were over 21,000 suicides cases and over 420 controls during the study period. And what they found is that 2.3% of those who had epilepsy committed suicide compared to about 0.74% in the controls. And they adjusted for some very important factors. And if you can see in this slide, they then examined the association between epilepsy and suicide in those with and without psychiatric disease, and they stratified into various groups. And you can see that even after they adjusted for important confounders and excluded psychiatric disease, the rate ratio for suicide remained high in those with epilepsy. So here you can see the rate ratio is still about 2. And the risk of suicide was highest among people who had, and they call, this is the term they use, affective disorder. It was close to 20 actually. And what they found is that the longer people had epilepsy, the risk of suicide actually decreased. So whether it's people are adapting to their conditions and, if that's a possibility, but that is one thing. Another thing they found is that though more men than women committed suicide, the association between epilepsy, psychiatric disease, and suicide was stronger in women. And you can see the rate ratio is 23.6. So because it is associated with the risk of suicide, this is Gus Baker is a prominent epilepsy researcher in the field, and in 2006 he said because it is risk of suicide is life-threatening, is considered a life-threatening disease, we really need to make sure that we screen for depression. So it's really important that as epileptologists, and I can say this for many of the neurological conditions, we see similar patterns. So very important to think about depression and epilepsy and anxiety. Just a few side studies and side notes. Back in 2009, there was this alert that was posted by the FDA, and I'm sure many of the psychiatrists who are on the line are also remember this. And this was very difficult for us as epilepsy specialists because there was a warning that anti-epileptic drugs were associated with suicidal behavior and ideation. Unfortunately, all the drugs were sort of grouped together, whether they had mood stabilizing effect or not, and so on. So as epilepsy specialists, we had many patients who just abruptly stopped their medication, not realizing that the risk of stopping their anti-seizure medication could be very high, and perhaps they were on an anti-seizure medicine with mood stabilizing properties and really had not had any depressive symptoms or anything like that. So it was a very something that was very concerning. And some of the issues with this warning is that adverse event data rather than systematically collected data were analyzed. And as I mentioned before, all the drugs were grouped together. So around the same time, this one group here in the UK used the Health Improvement Network data, which is EMR data, to look at the association between suicide-related events and people taking anti-epileptic drugs. And so it was an observational study, and they included people who also had epilepsy, depression, bipolar disorder. Within the study, they did some validation to make sure that the case definition for suicide was accurate. And the bottom line is that in the more than patients included in this study, they found that actually anti-seizure medications were not associated with an increased risk of suicide-related events in those with epilepsy, but it was in those who had depression. And so that was, there were a few studies like this that were done, and ultimately the risk is much higher in people with epilepsy who have depression or already have a psychiatric disorder. This is another nice study, and it demonstrates the importance of looking at things longitudinally and prospectively rather than just looking at an association over time. This is a study from Mary Jo Pugh using Veteran Health Administration data. And this includes people over the age of 65 who received a new anti-seizure medication prescription in 2004 to 2006. And what they found is, in fact, this is the adjusted odds ratio in months before and after index date. And this is when they have suicide-related behavior, where this little arrow is. And what they found is actually that suicide-related behavior actually peaked before exposure to an anti-seizure medication, suggesting that it was the symptoms that actually prompted an AED prescription rather than suicide-related behavior being rather than anti-seizure medication causing suicide-related behavior. So it's likely that the patient here, with epilepsy actually had suicide-related behavior as well. So when they were started on medication for their seizures, a neurologist decided to use a mood-stabilizing medication such that, it could hopefully also help if they had depressive symptoms and so on. So very important to look at things longitudinally, and you can see that after they start the anti-seizure medication, the suicide-related behavior actually goes back down. So because of many of these studies and others that have been published, the American Academy of Neurology in 2007 or 2008 published the updated quality metrics for people with epilepsy, and some of the variables that we should be considering when we counsel and see people in our clinics. And one of them is that we should be screening for depression and anxiety in people with epilepsy when we see them, whether it's in the inpatient or outpatient setting. So how do we screen for depression? And again, I'm a little humbled because I know many of you are psychiatrists and have extensive experience. I'm just a psychiatrist wannabe. But just like any other patient-reported outcome, whenever we, in clinical practice, we do like to use patient-reported outcomes because people can fill them out in the clinic and it saves time. And then if they're positive, or, we can explore these further once the patient comes into the room. So with any patient-reported outcome or PRO, whether it's depression or quality of life or something else, you want to make sure that the tool you use is relevant, that it has good psychometric property. We want it to ideally, and for example, at Sinai, we see thousands and thousands of people with epilepsy annually. So something that's in the public domain can be cost saving. We want something that's easy to administer. There's not a big burden on the patients. There aren't too many questions. It's easy to score. And in a place like New York in particular, if it's available in multiple languages, it's a big added bonus, right? So regardless of the PRO or screening tool that you use, it must be developed, implemented, analyzed, and reported rigorously and systematically. Now, many of you know that there are many, many depression screening tools. For some that are condition specific and not. And so I'm not going to go over how we develop a patient reported outcome, but just to say that, there are many things we need to consider. If there wasn't a good depression screening tool for a particular condition, or some of the standard ones didn't seem to be valid, then you would want to go through the process of, selecting your tool, developing it, and testing it, and then making sure that you decide how often you'll administer it and who will get it, and how will you score it and handle missing data and so on. So this is just for those of you interested in patient-reported outcome. It's a nice article that goes over sort of the development of patient-reported outcomes and so on. Because there are so many depression screening tool and other patient-reported outcomes, there's also a paper here. It's a systematic review that actually it gives a checklist that you can use to evaluate the property and applicability of patient-reported outcomes. So you can use it if you're trying to decide which one you should use. And there are 18 items, and then you can score it. And as long as the important items are captured, you may decide to take the one with the higher score. But it basically looks at, just like a depression screening tool or any other patient-reported outcome, was the conceptual model defined, what's the content validity, the reliability, construct validity, scoring and interpretation, how easy it is, and so on, and what about the respondent burden. So you can look at these things and try to score it and come up with, which tool you would use. But we were interested to implement a depression screening tool in our practices. So we decided to do a systematic review to see which one had been validated for people with epilepsy. And so we ended up screening over 16,000 abstracts, and in the end, 38 articles met all the eligibility criteria. They were, you can see there were 44 to 575 people in the study in terms of the range, with a mean of about 140 people per study. 30 studies looked at population and those who were 18 years and older. 7 looked at people aged 16 years and older, and only 1 was in youth. So at the time that we did this study, actually, there were no studies that validated a depression screening tool in children under the age of 10. What you can see here is the number of validation studies for depression screening tool in epilepsy, and you can see the different one, and by far the NIDI, which is the Neurological Disorders Depression Inventory for Epilepsy, there were 26 validation in 13 languages. And then you can see some of the Beck Depression Inventory, the Hospital Anxiety and Depression Scale, the PHQ-9, and so on. The PHQ-9 was only validated in English, even though it's available in other languages. And so the NIDI is a depression screening tool that's used a lot because it's short. There are only 6 questions. And patients find it easy to fill out. It's basically, the scores are from 1 to 4, and you can see the items here. Everything is a struggle. Nothing I do is right. Feel guilty. I'd be better off dead. Frustrated and difficulty finding pleasure. It eliminates some of the symptoms that are due to medication side effects, such as, low energy and that sort of thing. So this is why this has been one that's been favored, and it's available in many languages. And if the score is more than 15, it suggests major depression. So with any depression screening tools and studies that are done to validate these, people sometimes might find that a certain cut point is better. In the original study, a score of more than 15 suggested that people had major depression, but actually when we looked at all the validation study, people, including our group, evaluated different cut points, and you can see the sensitivity, the specificity, the positive predictive value and negative predictive value vary depending on what cut point you use. And what we found, I'm going to go on the next slide, is that, obviously the cut point you use is going to depend. I'm going to go back for a moment. If you want something that's very sensitive and you want to try to not miss anyone, you might go with a cut point of 11 for the NIDI, but that's going to decrease some of your other parameters, so that you're going to have lower predictive value, you're going to have more false positive and so on. So it depends on how much resources you have. What we found is that generally a score of 13 to 15 probably gave the best balance of sensitivity and specificity, and that's what most people use now. And some of the advantages of the NIDI is that it is free, it's in the public domain, it's very quick. It's the most validated one and available in many languages for epilepsy. And, but it's not validated in other populations. So if you have a study where you have people with and without epilepsy, it hasn't been validated for those without epilepsy. The PHQ-9 is also commonly used. Again, it hasn't been validated for epilepsy in any languages except in English, at least at the time that we did our study. Some people are concerned about using it maps to the DSM criteria, and some people get concerned about the ninth item that's related more to would be better off dead or hurting yourself, and the more kind of suicidal ideation and so on. And I'm part of a consortium that's doing individual patient meta-analyses from many validation study of depression screening tool with someone at Brett Toombs at McGill is leading this initiative. And we found that the diagnostic accuracy actually was the same if this question was dropped actually. So it seems that, you can use the PHQ-8 and you will have similar findings. So the PHQ-9 is also free and in the public domain. And for us, if we're doing studies and many people where there is a comparator group that doesn't have epilepsy, then that's usually the one that we use, again, because it's in the public domain and it's pretty easy to score and so on. And so from the systematic review we did looking at depression screening tool, we found that in general, most of the tools actually perform fairly well, that whether or not some of the symptoms included overlapped with side effects of anti-seizure medication or cognitive symptoms that people may have. As I mentioned, the NIDI was the most commonly validated one. And so in the end, the tool you use really depends on the resources you have and so on. We usually use the NIDI or the PHQ-9, but the other ones, are really perform almost equally as well. And really the important thing is to screen, and then you have to confirm whether they do have it or not. And there has been a similar systematic review looking at anxiety screening tools, so there is guidance as well in terms of which tool should be used for epilepsy. So in terms of gap, when it comes to depression and anxiety in people with epilepsy, we know that many people are not screening for these, even though they should be. It's important that these get incorporated at point of care. And we need better prospective data to understand how often are these screened for, are people being treated for these, so do people screen and then they don't do anything. So some people don't screen because they don't know what to do. They don't know, they don't want to start an antidepressant if it's a severe depression. They don't have mental health support in their program and so on. So some people just don't do it, but it is really important. And we need to understand what's the best way to treat it. So believe it or not, there are 2 old randomized controlled trial of antidepressant in people with epilepsy, and they're for drugs that are no longer on the market. They were pulled because of safety concerns. And the randomized controlled trials that exist now for the treatment of depression and epilepsy are mostly for self-efficacy and self-management. So there are significant gaps in terms of what's the best way to treat depression and epilepsy, and does it actually improve outcomes and so on. And there's very little information in terms of how do we identify mental health condition in children and in older adults. That's also a huge gap. So for some of the learners and trainees, that those are areas that where we need more research done. So that's what I wanted to say. Whoops. Okay, so the next topic I wanted to discuss is mortality and epilepsy. And so there's been a lot of work over the years looking at premature mortality and epilepsy. That's the better term because we're all going to die. It's just how soon. And so we often refer as premature mortality. And there's been study. This is a systematic review looking at low and middle income countries. And really, whether you look at low middle income or high income countries, the causes tend to be the same. It's just the proportion may be a little different. So in low and middle income country, those who have epilepsy have a 2.6-fold higher range of dying prematurely compared to the general population. And depending on the study, it could be up to 7-fold. And the main causes of death are related to epilepsy-related complications. So status epilepticus, SUDEP, sudden unexpected death in epilepsy, or sudden unexpected death in epilepsy and injuries are the 3 most common. And you can see that for the most part, these are preventable deaths. Many people drown or have other injuries that are preventable. Status epilepticus, many people in low and middle income country, in some country up to 90% are not on any treatment for epilepsy, and so they have big convulsive seizures that increase their risk of dying. And so these are preventable deaths. This is very similar, the same group. This is in the high-income countries, and really they found the same. They found that important causes of death among people with epilepsy in high-income countries include, again, injuries, status epilepticus, and SUDEP. Again, many of these were preventable deaths. So now, I focused a lot on depression and anxiety, and I'm going to come back to it now in the setting of premature mortality. And so this is a study examining the prevalence and the risk of premature mortality from external causes such as suicide, assaults, and accidents in people with and without epilepsy. Or I'm sorry, in people with epilepsy with or without psychiatric comorbidity. So in this study, nearly 9% of people with epilepsy died. So this was using This is a study, I believe that this is from Denmark. I apologize. I think that this was the Danish group, or I'm pretty sure it was the Danish or UK data, actually. Swedish data, neither. But they found that almost 9% of people with epilepsy died during the study period. And of those who died from external causes, they found that more than 75% had comorbid psychiatric disorder, very high proportion in people with epilepsy. And you can see what they did is here, I apologize if it's small, but they look at the different causes: suicide, vehicle accident or other accidents, any psychiatric disorder, depression, and substance misuse. And then what they have is the first row is when they don't have either epilepsy or a psychiatric disorder. The next row is if they only have a psychiatric disorder. Then if they only have epilepsy and not a psychiatric disorder, and if they have both. And you can see that if we look at suicide or suspected suicide, you can look at the adjusted odds ratio that if somebody has epilepsy, say they have depression, they have almost like a 10, they have 10 times the odds of dying from suicide. But if they have both, this increases to almost 23, very high adjusted odds ratio. Same with substance misuse. If they have both, very, very high. It's higher for depression than epilepsy alone, but once they have both, very, very high estimate. So again, a very, very important to consider a psychiatric comorbidity of epilepsy. This is a study this time, again, focusing on mortality, this time on sudden unexpected death in epilepsy. This is a study in children. And they did a systematic review and looked at all causes of death and so on, and found 22 studies. And the bottom line is that this was published in 2018, that they said that it was very hard to determine the etiology of pediatric SUDEP. We know that we used to think that the risk was lower in children than adults, but more recent, very elegant data found that actually the risk of dying of sudden unexpected death is the same. It's about 1 in 1,000, whether you're an adult or a child with epilepsy, and that risk goes up to 1% per year if you have drug-resistant epilepsy, meaning that you failed 2 medications that are appropriate for your syndrome and you're continuing to have seizures. So in children, the etiology is challenging. There's been a big study called the Mortimer study that found that generally SUDEP occurs often in the setting of a big convulsive seizure, and that it appears that what happens first is there's a respiratory arrest and then a cardiac arrest. So this is more data from this time for SUDEP from the North American SUDEP registry, and they looked at comorbid condition reported in cases of SUDEP, and you can see what they are. And they found that many who died of, had clinical feature known to be associated with SUDEP. So young adults, non-adherence with anti-seizure medication, and frequent generalized tonic-clonic seizures. In this case, in the SUDEP registry, they found that 70% of death were in sleep, and almost 70% were prone. So sleeping face down or on your stomach, if you have epilepsy, is not a good idea. And it does increase the risk of SUDEP, particularly if you live alone and there is no one that will hear you if you have a big seizure. In 2017, the American Academy of Neurology published the SUDEP guidelines to help providers with counseling during epilepsy visits. And I think one important factor to keep in mind, and again, they said that they had said it was about 1 in 4,500 in children. That number has now been changed to 1 in 1,000. And you can see in adults, the risk is about 1 in 1,000, much higher if people have ongoing seizures. But one thing that I wanted to highlight is that if someone has 3 or more generalized tonic-clonic seizures per year, they have a 15-fold increased risk of SUDEP, sudden unexpected death in epilepsy. This is a huge risk factor. We know that this is, a big thing. And so if somebody is continuing to have bilateral convulsive seizure, Even if they say, oh, I only have 2 or 3 a year, it's very serious. You know, they have a high risk of SUDEP. And so anyone with, you know, ongoing seizures, we do all we can to treat them. This is particularly important in these cases, that these people be referred for an epilepsy evaluation to make sure, one, that they're on the correct medication, or first, that they do have epilepsy, two, that they're on the right medication, and three, if they have tried adequate and appropriate medication, that they be evaluated for epilepsy surgery. This is another paper that looks at, you know, how do we prevent epilepsy-related mortality, and, you know, certainly medication adherence is extremely important. Again, mostly because we're trying to prevent, especially big convulsive seizures, psychiatric comorbidity, managing those. We know that people who have depression and epilepsy have many have suicidal ideation, and they have a higher risk of mortality. Healthy lifestyle, avoidance of trigger, again, to reduce the risk of seizures. So many things are done to prevent the risk of seizures, but I've also seen people where they're completely, you know, well controlled, but continue to have depression. And so that's why it's so important to address it, because just treating the seizures does not eliminate all the other negative psychosocial outcome in some people. And so how do we minimize premature mortality in epilepsy? Well, as I said, making sure we have the right diagnosis, making sure they're on the right treatment, making sure that, you know, if they have generalized tonic-clonic seizure, bilateral convulsive seizure, we address those. Early surgical referral for those who are drug resistant and continue to have seizure despite appropriate treatment. Make sure we prevent injuries, drowning, burns, and so on, and education about self-management. Sometimes we think someone is drug resistant, and we establish a good rapport with them, and they become very honest and tell us about all their bad behaviors, and we can work with them to improve their self-management, and then their seizures become well controlled. One of the last study I want to discuss is this most recent study, again, published by the same mentee that I mentioned before. This one is, it was looking essentially at to determine if the level of care, whether someone was seeing a non-neurologist, a neurologist, or being seen in a comprehensive epilepsy program, whether this type of care was associated with the risk of premature mortality. So this was it was a retrospective cohort study. It was in adults age 18 and older, and it was using administrative data, but also the Calgary Epilepsy Program Registry. So the comprehensive program that we had, which with validated diagnoses and so on. This was our prospective cohort data, basically. And so what we did is we wanted to see if the different level of care was associated with mortality. And one would think that if you're being seen in an epilepsy program, you probably have more complex, difficult to treat epilepsy. And what was interesting is, first of all, we identified over close to 24,000 new onset epilepsy cases. 40% had received care by a neurologist, 9% had been seen in a comprehensive epilepsy program. And the overall mortality during the study period was 7.2%. But when we looked at the standardized mortality rate stratified by the type of care, if they were not being followed by a neurologist or epileptologist, 9.4% died during the study period. If they were followed by a neurologist, it's 5.6%, and in an epilepsy program, 2.8%. And I'm sure you think this is, you know, inconceivable, and maybe we were just really excellent epileptologists there. but oddly enough, this I'm going to show you another paper that confirmed the same thing in the UK within a month of the study we published. So here's another figure from our paper looking at the cumulative hazard of mortality over time. And what you can see is that those who were, the hazard ratio of mortality was lower in those receiving neurologist care, 0.885, so they have a Sardashia period, and comprehensive epilepsy care, 0.49. So you can see that over time, those who were followed in an epilepsy program, you can see the cumulative hazard of mortality over 10 years. Those who were being followed by neurologists, a little higher, and those who weren't followed in either was higher. So And we adjusted. So some of you may say, well, maybe those who are not followed in a comprehensive epilepsy program or by a neurologist, maybe they were so sick, or they were people who were end of life, or other things like that. We did adjust for comorbidity. We adjusted for age and sex and various other factors and possible confounders as best as we could. So this is the other study that I mentioned, published also last year within a month of our study, this time looking at children and essentially finding the same, that among adolescents with epilepsy, that greater involvement of tertiary specialists in pediatric care was associated with a decrease in all-cause mortality. So very interesting findings, need to be reproduced, but we thought that it was really interesting to see that. So there are other important epidemiological studies that are informing clinical practice that I didn't have time to talk about as it relates to epilepsy, in terms of prevalence of drug-resistant epilepsy. Why is it some people respond and not? Precision medicine related to that. How do we treat it? How do we treat that 30% of the population who aren't responding to medication but represent 80% of the healthcare cost of epilepsy and have such terrible outcomes? What about outcomes in children born to mothers on anti-seizure medicine, the incidence of suicide, the risk of injury, and so on. So there are many things where, we know some of the findings, but we need some interventions to decrease some of these poor outcomes. We need more better prospective studies and interventions, again, aimed at minimizing these negative outcomes, and better prospective and systematically collected data at the point of care so that we can better understand baseline practices and inform future intervention. So in conclusion, basically, as I mentioned, more studies are needed again all the time to understand some of the epilepsy outcome, and particularly how to best treat them, such as depression and epilepsy. I think that, many of us are starting to use e-learning health systems more and more to help us gather data and understand, and linkages to many different types of data, whether it's biological, clinical, and so on, is important to really help us, have a broad approach to understanding all these issues that we face and how best to address them. And then ultimately, for many of the things we talk about, such as depression, multifaceted intervention that are interdisciplinary will be required. So these were, the different students, coordinator, research assistants, and who helped with the studies that I showed you. So I want to thank them for their help, including this very small person. And also, I'd like to thank some of my collaborators and mentors who were involved in some of the work that I presented today. And so thank you all for your time, and I'd be happy to take some questions.
Thank you, Nathalie. That was great. Applause from everybody here. So let me start out with a question. I've known for many years about the comorbidity between epilepsy and depression. And I remember when I was in psychiatric training, one of the rationales given for the initial use of ECT, or electroconvulsive therapy, was some sporadic case reports over 100 years ago that people with epilepsy don't get depressed. So I don't know how people missed the comorbidity years ago. You may have mentioned this, and I didn't catch it, and I apologize. Has anyone related the comorbidity as a function of the number of seizures per day?
Mm-hmm. So, there are definitely the epilepsy is more severe. So if it's more disabling, if there are more seizures on more medications and so on, definitely there's a relationship, but not always. We definitely, I can tell you in practice, we see people who are doing beautifully seizure-free, everything else is fine, and still very, very depressed, Mm-hmm. So though that there is a relationship, it's not always the case for everyone.
Mm-hmm. Mm-hmm. And has there been any attempt to relate the location of the seizure focus with incidence of depression?
So definitely, and there are some, there are imaging studies,
Mm-hmm.
there are, whether it's functional, structural, and so on. People have looked at, particularly the temporal lobe, some of the limbic structures have been studied. So certainly, there are more studies where, definitely frontal and temporal lobes that the association is greater. Mm-hmm. But again, it's an area where, you know, more studies are needed.
Mm-hmm.
Yeah.
Great talk. Thank you so much.
My pleasure.
I was surprised by the ONFI study, you know, where you had this where you were trying to study the withdrawal symptoms when there was the shortage on ONFI, and you found these qualitative differences, and that was great. But were you surprised that there were so few, you know, clinical outcomes? I thought this was associated with, you know, dramatic increases in seizures if you would suddenly stop the medication.
We were very surprised. And so just let me tell you, like, some of the patient-reported outcomes we were capturing were epilepsy severity, how disabling it was. So there are scales we were using: depression screening tool, the GAD-7 for anxiety, the quality of life, and so on, and other variables like that. And none of those, and maybe was the period too short? You know, if we went another couple weeks, would we have seen that? Because it was within 3 or 4 weeks. So some people were literally, it had been just 2 or 3 days that they had figured out that they couldn't get it, you know. And so it's possible it was too early. And if we had, you know, repeated it, and we didn't want to do something retrospective, that's the thing, we wanted to do it while it was happening. So whether a lot of it were more adjustment reactions and they were just acute kind of crisis, you know, we were shocked by how many people were literally calling Epilepsy Foundation, calling our program, crying, saying that, leaving messages saying, if I don't have the clobazam tomorrow, I'm going to kill myself, you know, and things like that. It was very dramatic. So I think a lot of it was panic as well. For people, many people, to tell you the truth, were more the ones who had been controlled for many years, who were doing well, and the thought of, you know, not being able to drive and this and that, and, you know, was very frightening, thinking that I'm not going to get it, and now I'm going to have a seizure, and my whole life is going to be turned upside down. So to tell you the truth, it tended to be more those who had been doing better, and now we're so afraid to, you know. But yeah, we were surprised at the patient-reported outcomes. So this is when my life changed, and I became the mixed methods researcher, you know, and I thought it's always important to do both, you know, and just to inform sort of next steps. And yeah.
Nice, thanks.
You're welcome.
Nathalie, again, thank you so much for joining us, and thanks to you and your team for doing so much during the peak of the pandemic as well.
My pleasure.
Really appreciate it. Thanks so much, everybody. Thanks for joining us. Bye-bye.
Thank you.